I yield back.
Gentleman yields back. Now recognize the gentlelady from Illinois, Ms. Kelly.
Thank you, Mr. Chair, and I want to thank the chairs and ranking members for your insights on the challenges and successes we've had faced in strengthening our response to the COVID-19 pandemic, and excuse my voice. And I want to thank the witnesses for all the work that you do. Vaccinations have proved to be a powerful tool. The Biden administration's decision to make vaccinations free was a pivotal step in our continuing journey toward health equity. In response to reluctance in communities of color to get vaccination, the evolution of COVID-19 messaging created opportunities to address challenges and create strategy around increasing confidence in public health messaging for Black and brown communities, including continued efforts to increase vaccination rates and booster compliance. Still, bivalent booster rates continue to lag, with 19.4% of Black communities, 12.7% of Latino communities receiving updated boosters as compared with almost 30% of white communities. Dr. Walensky, considering the pending PAHPA reauthorization, are there key learnings from COVID-19 that will help to increase Black and brown awareness and uptake of public health strategies during the ongoing pandemic and other future public health emergencies, because there will be others?
Yes, there will be others. Thank you for that question. Among the key points of our CDC moving forward is creating partnerships, results-based partnerships, and part of those partnerships is working with community-based organizations, recognizing that people know how their communities will react and people know their questions that they'd like answered. We do have programs like Vaccinate with Confidence, race and ethnicity access to community health, Let's Rise, promoting vaccine confidence. So all of these things are working within communities with people from those communities to understand what it is, what are their questions, the local questions that they have related to vaccine confidence. It's a concern not only for COVID-19, but also for other routine pediatric vaccinations as well.
So I know COVID's not over, but it's waning. So do you see that continuing, or we just did that during COVID?
Those efforts are continuing not only through the bivalent boosting, but we always have a vaccine campaign for flu vaccines every year. And then we really do have work to do in our pediatric vaccines. As has been noted, we lost pediatric vaccination rates this year down from 95% 2 years ago, 94% last year, 93% this year, 250,000 less children entering kindergarten with their routine vaccinations being up to date.
Thank you. How do you say your name? Tabak, I want to be correct. Dr. Tabak, can you elaborate on how initiatives such as NIH's SEAL, Community Engagement Alliance Against COVID-19 Disparities, increased clinical trial diversity for COVID-19 vaccines and treatments?
Yes, I'm pleased to do that. What we did was we partnered with local organizations within the community, faith-based organizations and other community leaders, people who are trusted, and met with them to explain things, basic questions about COVID, about therapeutics, about vaccines, and importantly, why it's important to participate in clinical trials. We wanted our trials to represent the nation, and that, of course, gives better comfort to people that a particular intervention may work if they know that somebody who looks like them was part of the trial. We're building this into everything that we're doing now at NIH. We're not stopping just with the COVID response, because obviously the same tenet holds true for all clinical research. And so we're working hard to extend that.
I'm glad to hear that, because I was going to ask, how can the successes of these efforts be replicated to ensure racial and ethnic diversity in clinical trials more broadly? So I'm glad you're continuing. I just want to say thank you again. This is very important to me, and I look forward to partnering in a bipartisan way with my colleagues to ensure clinical trial diversity. Thank you. I yield back.
Gentlelady yields back. I now recognize the gentlelady from Arizona, Ms. Lesko, for her 5 minutes of questioning.
Thank you, Mr. Chair. My first question is for Mr. Tabak. You told Congressman Carter that NIH did not fund EPPP research in foreign countries except for an influenza experiment in the Netherlands. Was that experiment funded by a direct grant or a sub-grant?
The experiment in the Netherlands, I believe, was a sub-award, but I would have to check to confirm that. And that was done in I think it was in the early 2000s. It's been a while.
Okay, and how then did the NIH know about the experiment? It's a sub-grant.
It was approved under the then DIRC/P3CO framework, and we used the normal monitoring procedures for that, yes.
In the case of EcoHealth in the Wuhan lab, the NIH was unable to get the records of a humanized mice experiment because the Wuhan lab, the subgrantee, refused to provide this to EcoHealth. Given the failure of an NIH grantee to get lab records, there could be other cases where NIH can't get the lab records. Isn't that right?
It's possible. As you know, that sub-award has now been terminated. They are no longer funded by NIH to do anything.
So how can you state, how can the NIH know for sure that it hasn't funded EPPP when NIH can't be sure it can get the lab records of experiments funded by NIH?
As a result of them failing to provide us with the adequate documentation, they no longer have any funding from NIH. The NIH funding, we approve what they are to do from their progress reports and from their publications. They have done what they said they would do. The work was commensurate with the modest sums of money that we provided to them. I don't know what other work they're conducting there.
I guess what I'm saying is that if we couldn't get the reports accurately, how can you definitively say that there was no funding of this? And so anyway, I have another question for you. As the Vice Chair of the Oversight and Investigation Subcommittee and a member of the Select Committee on the Coronavirus Pandemic, I can't stress how inexplicable the failure, I believe, of NIH oversight on the EcoHealth Alliance grant is to me. In 2019, EcoHealth Alliance failed to submit a required annual report on the research it was conducting related to the emergency of the bat coronavirus. The 2019 progress report was due by September 2019. The COVID-19 pandemic began late 2019. Despite a bat coronavirus pandemic emerging in the city where NIH-funded bat coronavirus research was taking place, NIH failed to even ask for the missing progress report until 2021, and it was still not actually submitted until months later, more than 2 years after the due date. Given these circumstances, how did the agency fail to notice that the annual report on research done by EcoHealth and the WIV was overdue for 2 years?
The most important point to appreciate here is that the viruses that were under study in that sub-project bear no relationship to SARS-CoV-2. They are genetically distinct. They are absolutely unrelated to SARS-CoV-2. That's the most important thing to understand. As far as the administrative
And how do you know
oversight,
that for sure, sir?
by looking at the phylogeny by looking at the genetic sequence. It would be equivalent to saying that a human is equivalent to a cow. That's how distant the sequences of the bat viruses that they were using in this work were to the actual SARS-CoV-2. Now, the administrative overlap, the administrative issues, we concur with that. We concurred with the oversight report. We have taken steps to redress those administrative issues.
Thank you. I have only 13 seconds left, so I will yield back.
Thank the gentlelady, and now recognize the gentlelady from Washington, Dr. Schreier.
Thank you. Thank you, Chairman Griffith, and thank you to the witnesses for being here today. I appreciate all the work you have done over the past few years with a rapidly changing pandemic and tricky messaging. We have learned a lot in these past few years, and I just want to make sure that we remember these lessons when the next public health challenge comes along. Today, there's a lot to talk about, but I'd like to focus on testing and on therapeutics. So, Dr. Califf, in your testimony, you say that the FDA is committed to continuing to use every tool in our toolbox to fight this pandemic, and I absolutely agree. As a pediatrician, I've been advocating, now we're talking years, for the use of rapid tests and masks and a multi-layered approach to keep our kids and families safe and to keep our children in school, in classrooms. And I also just want to acknowledge, Dr. Walensky, thank you for you also having that as your North Star. How can we get our children into classrooms and keep them and their teachers there safely? In fact, we did one of the first pilots in the country on using rapid tests to get kids into school. The FDA has authorized over 30 over-the-counter tests, and I use them before I travel home to make sure I'm not bringing unwanted COVID back to my family. People use them around the holidays to protect their families, and we've really come to rely on these rapid tests. Are any of the ones that we're using today fully authorized, or are they all under emergency use authorization?
I believe all of the rapid tests that we have today are under EUA, but they will not go away because we'll have a bridging program, and they will still be available.
That is fantastic. You
I'll have to check to
anticipated
be
my
sure it's 100%.
Okay, I wanted to make sure that that would happen because they're really indispensable. I will hop to my other topic. Mr. Tabak, or Dr. Tabak, excuse me, the RADx program has been incredible. These public-private partnerships, getting accelerated treatments has been incredible. I was wondering if you could talk about how we are going to use this and stay nimble with future threats, but just kind of a briefer answer because I have more for you.
So from the lessons learned, we know that if we could create centers that are ready to take very rapidly the problem, find a solution, and then scale it up, that we could make a big difference in any future pandemic.
That public-private partnership has really been incredible, and I appreciate the work in all of these institutions, CDC, ASPR, BARDA. We've already seen with COVID that as the virus has changed, some of our therapeutics are no longer useful, like some of the monoclonal antibodies. And we know from our experience with TB and with HIV that we may get to the point where what we need are drug cocktails. Essentially, you don't just use one therapeutic in order to evade all of the mutations and changes in a virus and them getting around therapeutics. We may need to use several at once. There's not a lot of incentive for drug companies to do that testing. And I was wondering if you could talk about what is happening at the NIH to speed drug cocktails.
So in the ACTIVE program, which is a public-private partnership consortium between government agencies and industry, we have in fact used that as an incubator for these types of mix and match, if you will, types of approaches. And we've been very pleased for a number of our industry colleagues who've come forward and have been willing, to engage in this sort of conversation. So I think that's the direction that we'll have to proceed in the future.
That's fantastic. And frankly, they will have more of a guarantee of a long market life if they figure out how to make theirs more effective in a cocktail. Last question, Dr. Califf. I know there's been a lot of discussion about whether vaccines are still useful, even if they are not perfect at preventing the disease or perfect at preventing transmission. I just wanted to give you an opportunity to set the record straight on your perception of the importance of vaccines.
Really, first of all, let me just speak to the transmission issue, which has been discussed very much today. It's true that the vaccines are not sterilizing, and Dr. Bouchon, I think, was careful in using that word. What we have, though, is a modest prevention, like a 50% prevention of the risk of getting infected if you're up to date on your vaccination. And that's very important for frontline workers of all types to stay healthy, for children not to infect their grandparents who may be at risk. But the most important thing, I think, is if you're up to date, you've gotten your bivalent now, which is what that means, your risk of dying if you get infected is reduced by 80%. And if you get a antiviral that's recommended by the FDA, if you get infected and you're high risk, you have another 80% reduction. Now, you have to do contingent probability, so what that means is your risk of dying is very low if you get both. So, you know, I'm a cardiologist, so I'm used to life and death. This is like the most important thing one can do today to keep from dying that's very remediable, free. There are side effects to vaccines, we all know that, but they're far overwhelmed by the benefits that
Thank
occur.
you. As a pediatrician, I fully concur with the importance of vaccines. I yield back.
Gentlelady yields back. Now recognize the gentleman from Pennsylvania, Dr. Joyce.
Thank you, Mr. Chairman. I'd like to address the CMS vaccine mandates because I think we recognize that it has caused a cascade of problems, including workforce shortages throughout the United States on all levels. OSHA also released a mandate November 5th, which has been held up in the courts and then subsequently withdrawn. Dr. Walensky, was the CDC consulted in issuing these mandates?
The CDC provides information regarding the safety and effectiveness of vaccines and has provided the information that says that those vaccines are very safe, very effective in preventing severe disease and death, as Dr. Califf just said, as well as preventing some symptomatic disease. Not as good as severe disease and death, but about 50% protection against symptomatic disease, even during the Delta and Omicron era.
Did OSHA specifically reach out to you or your teams before issuing these mandates?
We provide our scientific guidance within an interagency process that works across different agencies.
Dr. Walensky, we're both Johns Hopkins trained physicians. We're both parents. Head Start has a vaccination mandate that is in place. Did the CDC provide data about COVID-19 risk to Head Start aged populations?
CDC continues to provide recommendations and information, science-based information on the vaccine safety and effectiveness in children and in adults.
In earlier testimony, you stated that the vaccine mandates with COVID-19 have resulted in decreased routine pediatric immunizations. Is this not correct?
I would have to go back to the record. I'm not sure I stated it exactly in that way.
Do you feel that with the potential of decreased routine childhood immunizations to measles, to mumps, to rubella, do you feel the continuation of the Head Start vaccine mandates will put at risk these children, or actually have their parents consider whether or not they should continue in these Head Start programs?
What I can tell you is that vaccines save lives. That is true in our routine vaccination for pediatrics. It is true in COVID-19. It is true in influenza. And I think we should do everything that we can to promote vaccination because it saves lives for all of these different infectious threats.
I feel that we're subjecting certain populations to more risks than when we recognize that parents are not immunizing their children with vaccine mandates, which we recognize are not necessarily effective, particularly in pediatric populations. I'd like to pivot and talk about the end of the COVID public health emergency. Unwinding the public health emergency will eventually reset the health system back to what was in place before the pandemic, with some exceptions. Unfortunately, and it really is unfortunate, I do not feel that we will restore in our public health agencies the credence that is so necessary at any time soon. Dr. Califf, as a follow-up for my September 2022 letter, with explicit steps, what explicit steps is the FDA taking, or will the FDA take, to continue to move forward on COVID-19 therapeutics, specifically therapeutics that so many patients continue to need, patients who are immunocompromised, from whether that's from underlying disease or patients who are immunocompromised because they're in the middle of a cancer therapy, patients who are exposed to many different types of infectious disease, but particularly to COVID-19.
Well, let's talk about the technical aspects first, and I appreciate the question because there are millions of immunocompromised people, as you know, in the United States. They deserve special protection. We have now the ability to make therapeutic antibodies, as you well know. In addition, the first step is get vaccinated, be up to date on your vaccination, make sure if you get infected that you get a potent antiviral. Those are available, they're effective in compromised patients as well as other people.
My time is limited. Please allow me to interrupt. So the therapeutic antibodies, are they effective against the current strains that we see with COVID-19?
None of the ones currently available are
So we're
effective
talking
against
about
the
what is going to be available. If we recognize that the immunotherapies are not, per you, are not effective against the current strains, what do we have to offer these patients?
I think the way to think about this now is that the technology has gotten so advanced, there's like a library of therapeutic antibodies. Don't be surprised if you see some that were old and didn't work against old strains, now with the new variants actually becoming active against them. So those are constantly being tested. But we also need to work with the industry to figure out a way to make it worth their while to continue to work in this field, because what they're looking at is they make a therapeutic antibody, 3 months later, there's a new variant, and there's no longer a market for it. One of the real keys to Operation Warp Speed and to what came after was the government infusing money that took the risk away for the industry for being active to use all their capabilities. So we do have work to do there, but
I
the
think
technology
my
is there.
time has expired. I think we have a lot of work to continue to do. And thank you, Mr. Chairman.